everyone. Thank you for inviting me. I'm delighted to be here. I'm a clinical cardiologist, and I'm by no means an immunologist, but your input and your questions are always welcome and will inspire me. My topic is innate immunity in cardiology, and I will go through two very important topics. And the first one is vessel, and that is coronary artery disease. And the second one is the valve, aortic stenosis. I have nothing to disclose. As we know that myocardial infarction is life-threatening, and 5 types have been defined according to their mechanisms. And vasospasm accounts for the type 2 myocardial infarction. And this is a 64-year-old female who came into my office with the presentation of chest pain, weakness, and frequent episodes of loss of consciousness. And 5 years ago, she received a stent implantation in right coronary arteries. As we know that on the heart, we have 3 coronary arteries, and there's one in the right and 2 in the left. She received a stent implantation in the right coronary arteries, and now she complained of chest pain. So because this is a post-stent implantation chest pain, so this is an indication to do coronary angiography. So I did the coronary angiography, and no restenosis was found in the right coronary artery. So the next step is to proceed with a spasm provocation test to see if there's any spasm. And during spasm examination, the spasm appear in the middle side and the ostium and the distal side. And at the same time, the life-threatening ventricular fibrillation occurred. And an electrical shock was given, and intracoronary nitroglycerin was given. And then the coronary artery returned to normal size, and there's no stenosis. The patient's consciousness remained clear throughout the whole course. If this arrhythmia, if this ventricular fibrillation persists for more than 10 seconds, you will lose your consciousness. And if this persists for more than 10 minutes, your brain may have irreversible damage, and people may die. And this is a middle-aged man who came into my office with complaining of chest pain after waking up at night. And during the baseline examination, the coronary angiography revealed no restenosis. So I did a spasm provocation test, and the spasm first appeared at the ostium. Then they progressed to the whole vessels. And at the same time, the ventricular fibrillation occurred. This is life-threatening. And the arrhythmia persists for just 10 seconds. Then it spontaneously recovered before we gave him electrical shock. His consciousness remained clear throughout the whole course. So in patients with syncope or chest pain, the spasm always should be a differential diagnosis. According to Dr. Selwyn's study in Harvard Medical School, there's racial heterogeneity in the frequency of spasm. In the United States, only 2 to 3% of all patients undergoing diagnostic cath for chest pain are found to have coronary spasm. However, in Italy, the frequency is 10%. In Japan, it is more higher. It's 10 times higher than the US. In Taiwan, we found that 25% of unstable angina or myocardial infarction patients have angiography normal coronary arteries. However, about half of them is due to coronary spasm. They are not really normal. And most of patients with spasm are men. And the mean age of these patients is between 51 to 57 years. Regarding white female patients, this is data more than 10 years ago, and this data has not been updated. So regarding female populations, it's questionable. It's questionable that is it true that white female patients is higher than Japanese female patients? For diagnosis, the EKG and exercise tolerance test is highly variable in the results. So this is not trustable. And coronary angiography is the gold standard for the diagnosis of coronary spasm. Of all the provocation test agents to induce coronary spasm in susceptible patients, ergonovin or methylergonovin, acetylcholine or hyperventilation are the most useful. And ergonovin malleate is no longer available. In the United States, only methylergonovin is available. In Taiwan, in our study in Taiwanese patients, patients with spasm have higher monocyte count compared to patients with no spasm and no coronary artery disease. In regression analysis, peripheral monocyte counts and C-reactive protein carry high risk of coronary spasm development. In all patients, smoking has a higher risk of developing spasm in younger subjects than in older subjects. In smokers, male gender has a higher risk of developing spasm than female. And in non-smokers, the risk of developing spasm is only demonstrated in patients with the highest tertile, CRP tertile. However, in smokers, there's a positive linear monotonic trend between C-reactive protein and the risk of developing spasm, suggesting that smokers develop spasm at a lower CRP level than smokers. That is, there's an interaction between CRP and smoking. In our study in Taiwan, we found that these patients, most of these patients are between 40 to 70 years old, and their prevalence decreased after 70 years old. And this results, the case is also true in the Japanese study later. And this age distribution is in striking contrast to the coronary artery disease. According to the American Heart Association, aging predisposes to coronary artery disease. And the spasm age distribution, the pattern, is very similar to a hantavirus outbreak in Finland about 10 years ago. And this rings a bell in my mind that is that possible that spasm may be related to infection? In coronary artery disease, hemoglobin is associated with coronary artery disease mortality. Their relationship is J-shape. High hemoglobin level carries a higher mortality in coronary artery disease. In coronary artery spasm, we found that patients with spasm have a higher hemoglobin levels than patients without spasm in figure A and B. And A is women and B is men. However, the pattern is less clear in men. As people age, platelet counts decrease. We found that patients with spasm have higher platelet counts than patients without spasm. although the pattern is less clear in women. And regardless of CRP level, we found that diabetes and hypertension are associated with lower risk of developing spasm, especially in women. So far, there are 3 risk factors for developing coronary artery spasm. One is age, the second one is smoking, and the last one is CRP. Risk factors often coexist and interact with each other to develop spasm. However, the precipitate factors in gray circles may cause the onset of spasm in the same patients under different conditions. And we also found that the occurrence of spasm in winter and spring portends a worse prognosis than patients developing spasm in summer and autumn. And this paper just published in JACC this year. So in summary, if you are a middle-aged man who smoke, if you are male or female living a stressful life, and if you are doing a Valsalva maneuver, and which is that when you perform a forceful exhalation against a closed mouth, and that's what you do when in the restroom, or if you are alcoholics, you will put your coronary artery disease in risk of developing coronary spasm. And regarding the blood components contributing to coronary spasm, so far, monocyte, red blood cell, platelet, and CRP are the most important. So further studies are needed to define their role in the development of coronary spasm. So moving on to the next topic, I'm going to talk about aortic valve stenosis. This is the normal aortic valve. It has 3 cusps, and the surface is smooth. And when people age, the aortic valve becomes thickened and calcified, and it causes the amount of blood through the valve becomes less. It appears like a cracked water pipeline through which the blood is forced out, just like this. So the pressure gradient and the velocity will be increased compared to normal people. And aortic stenosis is the most common valvular heart disease in Western world. The first leading cause is aging and calcific. And just like I said, a normal aortic valve has three cusps. But when people have bicuspid aortic valve, it has a risk of developing coronary spasm. And this kind of cause is the second leading cause of aortic stenosis. And this is the normal aortic valve. And when aortic valve ages, the calcification may develop and deposit on the valve leaflets, causing the valve difficult to open. In bicuspid aortic valve, calcification may or may not occur, resulting in varying degrees of aortic valve stenosis. So why is calcific aortic valve stenosis so important? Because it can cause heart failure and sudden death. In epidemiology, in people over 75 years old, 2 to 3% of these patients have this disease. However, valve sclerosis, not stenosis, the prevalence is about 25% over 65 years old. And sclerosis is the earliest stage of aortic stenosis. The risk factor is similar to atherosclerosis. However, 50% of calcific aortic valve stenosis don't have clinical significant atherosclerosis. In experimental models in mice, so far there are only 2 models develop aortic valve stenosis. Other models develop only valve sclerosis. Among all interventions to retard progression of calcific aortic stenosis, studies have been shown to have no effect on stenosis progression. Regarding osteogenesis, there are no there are not many studies so far. It needs further study. And regarding angiotensin-converting enzyme inhibitor, it has been shown it has no effect. And regarding angiotensin receptor 1 blockers, it has been shown to prevent inflammatory cell infiltration. However, many studies have conflicting results, so it needs further study. How about PPAR gamma? It has been shown that it can prevent differentiation, prevent the endothelial cells of aortic valve differentiation to osteoid cells, therefore slowing the progression. However, it needs further study. Under oxidative stress and aging process, oxidation-specific epitopes develop, and they can be recognized by receptors, antibodies, and proteins like CRP. And EO6 antibody is a kind of natural mirroring antibody. So based on that concept, we developed a transgenic model of LDLR knockout EO6 transgenic mice models to study the development of LT valve stenosis. If EO6 transgenic mice can be shown to have slower progression of LT stenosis, it will be reflected by a lower velocity, LT valve velocity, compared to LDLR knockout mice. So we have two groups of mice. One is transgenic mice, and the other one is LDLR knockout mice. And all mice were fed 1% high cholesterol diet after 3 months old. And they received heart echo study at 6, 9, 12, and 15 months old. And after 15 months old, their blood samples were collected, and their organs were harvested. So in Sudan 4 in UNFAS Sudan 4 study, the aortic valve, the aorta atherosclerotic lesions is much severe than transgenic mice. In Vaccination study, the aortic valve thickness is much higher than transgenic mice. And this is the profile of aortic valve hemodynamics and atherosclerotic lesions. A and B are the representative photographs for transgenic mice and knockout mice respectively. And in heart echo, aortic valve cusp separation is larger than knockout mice. In Vaccination stent section of the valve, the transgenic mice have thinner aortic valve compared with knockout mice. And Sudan 4 stent aorta lesions shows a much lesser atherosclerosis than knockout mice. And considering the peak transvalvular systolic gradients over time, we can see that there's a trend to a higher transvalvular gradient in knockout mice. And at 12 months old, the mean transvalvular systolic gradient is much higher in knockout mice than transgenic mice. And the Kaplan-Meier survival curve shows that at the end of the study, there's not even one transgenic mice found to be dead. However, half of knockout mice die at the end of the study. So the mice study were done in University of California, San Diego. There are two very important mentors because of their selfless mentorship. So this work can be done. And one is Joseph Whiston, and the other one is Dr. Simikas. And this is my university. Most most of spasm study were done in here, and the mice study were done in UCSD. Thank you.